Welcome everyone to this session, and I will take advantage of what has been presented in the previous speeches in order to focus at best on what is the clinical relevance of diagnostic testing, because the issue of COVID is not only having the tools to diagnose them, but also to apply them in clinical practice. I mean, the major problem that we have today is the sensitivity, specificity of the methods, but also what they mean in practice, how to use them properly. Just to repeat what has been done in the previous year, the pandemic is very tight in time. The virus entered in Italy, and then we can distinguish 4 different phases of the infection, at least in Italy. We started, unfortunately, earlier than the others, and now we are just following the stream in Europe. In particular, let me distinguish a first phase, the entry of the virus, a second phase, stabilization of the virus, a third phase, that is the summertime, the partial disappearance, and October, the reappearance, the strong reappearance of the virus. Here you see what happened in the first phase when more than dozens of thousands of swabs have been done. You see that in the emergency room in red, that a substantial number, up to 78% of the total swabs done in the emergency room at the hospital where I was until July, were COVID positive. This provides you an evidence of what was the situation at that time. And this is the situation in the second phase in May. You see that the red part shrunk and was very minimal at that time. That corresponded with the exit from the emergency. Then we enter in the third phase. That was the summertime, which the columns were mostly gray. The emergency room, emergency department became again what it was in the past. But we have the fourth phase. You see that from September and beyond, we started again to see the red in the emergency department and in general, with a number of cases that is again closer to what it was before. Why is it important, this part, to introduce my speech? Because the issue is that doing swabs gives an idea of the circulation of the virus. But swabs have been done in different ways in different parts of these phases. In the first phase, we did mostly swabs in patients with advanced disease. We couldn't search in asymptomatics, while now we actively search for asymptomatic people. So it seems that the number is very close to what it was in March and April. That's not true, because in March and April, we did not diagnose the asymptomatic people. So the situation is impairing. It is very clear that it is impairing, but the real numbers are not those that are reported here. The same swab can diagnose asymptomatics, can diagnose paucisymptomatics, can diagnose heavily symptomatic people. We need to know how to use them and in which conditions. So let me enter in what we did for the diagnosis of COVID, and let me express and present to you what has been done and by our group in order to activate the discussion and see which is the situation in different countries. The first paper that is quite advanced, is no longer under review, is demonstrated that by full-length sequencing of the virus, taken from more than 150,000 swabs that we did at the Niguarda Hospital during the period that was the period of the pandemic. This demonstrated that we had essentially 7 viral lineages, very similar to each other, with a minor point mutations that demonstrated a different entry at more or less at the same time of the virus within the region. So it was not a single entry, but a different entry. But this document that shows through full-length sequencing the characteristics of the virus tells us also that the variability of the virus is minimal. As I said, that there are 7 lineages, but they are very similar to each other. And this advocates for a substantial potential efficacy of a vaccine once a vaccine can be found. If we go beyond this study, we see that the search by swabs of asymptomatic patients makes a difference. We couldn't do it in spring, we do it now. And the reason is why we do that is that because driven by this study done in the spring, it demonstrates that the majority of patients do not undergo symptoms and they remain asymptomatics. However, a paper that was published this week in JAMA demonstrates that asymptomatic people might have the same viral load as it is the viral load of symptomatic people. So in terms of infectivity, symptomatic and asymptomatic may behave similarly. And this helps in understanding how to use the swabs in clinical practice. When to use the swabs? This is a key point. This slide, different to other, represents pretty well what happens in terms of viral load and antibodies during the course of the disease. Please note that the virus has its zenith at the time of onset of symptoms. And then it starts to decrease essentially because the number of cells that can sustain the replication of the coronavirus is limited by the killing driven by the virus itself. So there is a paradoxical effect that with the advancement of the symptoms and perhaps even in terms of gravity of the symptoms and eventually death, the amount of the viral load present in the late stages of the disease is lower than at the symptom onset. This needs to be considered in order to understand how to position the quantification of viral load. Indeed, we need to evaluate how to use the parameters that we have available. For example, the antibodies, as you saw in the previous slide, cannot help a lot in terms of diagnosis. They help in letting us know the number of people that have been infected and if these people maintains immunity. And in this paper that is currently submitted, it is quite evident that the number of people that got infection is relatively high. You see the numbers are substantial. About 5% of the total people that have been tested resulted to be positive, but the antibodies tend to wane over time. This is something that is crucial to understand how long the potential effect driven by a vaccine will remain. We have no clear data at this point. The perception is that the immunity doesn't remain similar over time. We will see. But probably more important is the use of RT-PCR in practice. This paper that we published in the Clinical Infectious Diseases a couple of months ago shows something that is very common for all those that work in virology, that the higher is the viral load, the greater is the mortality. So the gravity of the symptoms. You see that those that have a CT very low, that you know that represent very high viral load, less than 20 corresponds more or less, we did by digital PCR, more or less corresponds to 15, 20 million copies of the virus minimum. You see that the mortality early and in quantity is far greater than in those that have a lower viral load. This is not surprising and advocates for quantification of the test rather than only quality. So the conclusion is that the CT below 20 remains one of the strongest predictor of progression and death. This needs to be taken into account when we decide what to do with our patients. But remember, CTS, that is a viral load, needs to be tested at the onset of symptoms for the reasons that we said before, that the viral load tends to decrease over time, even in case of increase of the gravity of the symptoms. And how to use digital PCR to improve the diagnosis, because it happens that swabs return to be negative even in case of symptomatic patient. And this other paper that very briefly that we did by using digital PCR shows that a substantial amount, 19 over 55 patients that had the symptoms without viral load positive by the classical methods turned to be positive by droplet digital PCR. And this is quite relevant because the patient that turned to be positive, at the end, the clinical situation impaired and the symptoms advanced. So this means that in terms of clinics, the result of a swab negative in presence of symptoms cannot exclude the presence of the virus. Sometimes and pretty often, the swab sample is badly taken by the nurse or the physician, and it turned to be negative essentially because it was not done properly in the patient. Going toward the conclusion, so digital PCR is a promising tool that we use now in clinical practice. Let me just finalize my presentation by seeing what happens after clinical recovery. And indeed, by studying what happens to the patients that were diagnosed symptomatics by swab and by clinics, we studied a substantial number of patients, 13,000 patients studied longitudinally, and we repeated the swabs over time during the course of their post-disease, that is after dismission from the hospital. And you see that the red shrinks over time but doesn't disappear. What does it mean? That there are patients that even 2 months after the onset of symptoms, they still have the viral load, the swab positive. Whether this represents a virus that is really infectious or it is a debris of virus that is no longer infection, this needs to be further demonstrated. But as a matter of fact, a minority of patients in red and yellow remain positive or partially positive, and they represent a problem also for social reasons, because they cannot be reintroduced fully in working activity without taking even a marginal risk. So in conclusion, we can say that we have good tools today for our clinical practice. They have been refined over time, particularly the swabs, the antigens that I didn't talk about essentially because of the lack of time. But as the matter that we have to deal with is how to use them in a proper clinical practice. A positive or negative results needs to be properly positioned in collaboration with the clinics in order to let the clinician have the proper information and treat the patient properly. Thanks indeed for your attention.